Hi, I'm Amy Lake. I'm an occupational therapist and a certified hand therapist at Scottish Rite Hospital for Children in Dallas, Texas. I'm excited to share with you today the impact of Therapeutic Camp on children born with a congenital hand difference.
It has been written that camp, if it is worthy, is one of the greatest socializing, humanizing, civilizing factors that can enter the life of a boy or girl. Therapeutic camping for children with chronic conditions is a concept that was proposed in the 1970s to provide a normal camp experience for these children, to provide psychosocial interventions to decrease the burden of disease, and to provide support, respite, and skill building through recreational activities. Many diagnosis-specific camp models have been established through the years and studied, such as spina bifida, epilepsy, pediatric cardiac conditions, and cancer. What we know about congenital hand differences is that they are present at birth, range from mild to severe, and can affect physical function, social interactions, self-confidence, and peer relations, especially in the preteen and teen years. Research has proven that children with chronic illnesses are at a greater risk of experiencing psychological difficulties, such as behavior problems, poor self-concept, and social withdrawal, and are at a 1.3 to 3 times greater risk of developing a psychological or social issue during childhood when compared to healthy children. We also know that having a hand difference can create social avoidance within the individual as well as others surrounding him or her. At Scottish Rite, we have attempted to address these concerns of self-image, self-esteem, and self-confidence by providing a hospital-sponsored hand camp for patients with congenital hand differences. Our first hand camp was a family camp established in 1995. Since this time, we have expanded into 3 hand camp programs: HD1, which is a weekend camp for kids ages 6 to 9 and their immediate family; HD 1.5, a weekend camp for tweens ages 10 through 13; and HD2, a week-long camp in the summer for teens ages 14 through 17. We've also been able to assist others nationally and internationally in initiating hand camps based off of our hand camp model. There are now camps offered in St. Louis, Florida, California, England, and Italy. To date, however, no research has been published on the effects of hand camp. The goal of our study was to evaluate the efficacy of a therapeutic hand camp for children with congenital hand differences. We chose to study our tween campers ages 10 through 13 and chose to look at participant expectation of camp experience, self-esteem, physical function, and relationships with peers. To obtain our patient sample, all current patients with a congenital hand difference seen at Scottish Rite between the ages of 10 and 13 were sent an application. Of the 200 applicants sent, 40 openings were filled on a first-come, first-served basis. Of the 40 attendees, 36 were consented, enrolled, and completed the study protocol. 2 declined, and 2 had incomplete data. Measures were taken at 3 time points: pre-camp, 1 to 2 weeks prior to camp; immediate post-camp, 1 to 2 weeks following camp; and 6 months post-camp. Each participant filled out a camp demographic form prior to camp, which was a self-reported questionnaire, including demographic information, family history and status, previous camps attended, and goals of camp. Participants also filled out 2 sections on the Promise, which is a patient-reported outcomes measurement information system that evaluates and monitors physical, mental, and social health in adults and children. The subscales we chose to include were peer relations and physical function upper extremity. These 2 sections, as well as the Rosenberg Self-Esteem Scale, a 10-item scale that measures global self-worth by measuring both positive and negative feelings about self, were filled out by participants at all 3 time points. A camp expectation questionnaire, a measurement to determine if defined camp objectives and goals were met according to the camper, was given pre and immediately post-camp only. It was important for us to have hand camp objectives prior to initiating our study. Our hand camp objectives are to enhance self-esteem, increase function and participation in activities offered in their home environment, increase relationships with peers, increase self-image and acceptance of their hand difference, increase desire to try new things without being fearful of failure, increase independence in functional daily activities, gain confidence in explaining hand difference to others, and acquire coping skills to manage negative reactions from others regarding their hand difference. Our demographics in this study showed of the 36 campers who completed the study, 22 were females and 14 were males. 28 were white, 5 were Hispanic, 1 was African American, 1 was Asian, and 1 was biracial. The average age was 11.17 years old. 72% of the campers had transverse deficiency, 6% had radial longitudinal deficiency, 8% had ulnar longitudinal deficiency, 6% had central deficiency, and 8% had overgrowth. In looking at the results of the study, the physical function portion of the PROMISE demonstrated a significant increase at both the immediate post-camp and 6-month time points. The peer relation portion of the PROMISE demonstrated a significant increase immediately following camp, however almost returned to baseline at the 6-month follow-up time point, possibly indicating the importance of these kids to connect and be together more than just one time a year. In addition, other confounding factors may have been present affecting this score, such as changes in schools, family, and social situations. The Rosenberg Self-Esteem Scale demonstrated a significant increase immediately following hand camp, as well as at the 6-month time frame, despite a slight decrease at 6 months. This scale of 0 to 40 indicates the higher the number, the higher their self-esteem. The same confounding factors as mentioned previously may have been present impacting this score as well. The Camp Expectation Questionnaire demonstrates a significant increase immediately following camp, indicating the expectations of camp were met by the majority of the campers. Some limitations of this study were that it was only a small number of campers studied with a diverse group of diagnoses. We would like to eventually separate out these diagnoses to see if camp affects each diagnosis differently. There were also many confounding variables at follow-up, such as school, family issues, social changes, environmental changes, and other impactful experiences that were impossible to tease out. We would love to study these campers for a longer period of time and assess our younger and older campers as well. What we as the authors can say with confidence is that hand camp has a positive impact on children born with congenital hand differences, should be considered by healthcare providers treating children with congenital hand differences, demonstrates increased self-esteem and physical functioning for at least 6 months post-camp,
and that research related to therapeutic camp for children born with a congenital hand difference is an integral aspect when identifying best practice interventions to increase a positive quality of life outcome. And I'm excited to share with you today that our journal article has finally been published by a peer-reviewed journal called Cogent Psychology. I want to especially thank Mary Beth Azaki and Pete Carter for instilling in me the importance of walking alongside these amazing children. For I've learned so much more side by side at camp than I ever did sitting across the exam table within the 4 walls of a hospital. Thank you.